Good day, Professor Gibson and everyone. My name is Anastasia Krasikova, and I'm a family nurse practitioner student at US University. Today, I will be talking to you about a case presentation on a patient with acute asthma exacerbation or adult pulmonary. My patient with initials AM, he was born August 18, 1983, which makes him 42 years old. He's a male and prefers to be called him, he's a white Caucasian. He speaks Ukrainian and Russian, and he's agreeable to my Russian translation, though he knows basic English. He comes on March 2nd, 2026, this Monday, unaccompanied, well known to the clinic, established patient with the chief complaint of, I've been short of breath since this morning, I ran out of my inhaler and other asthma medications. So the patient is well known to the clinic, and as he explained, he was driving his car again and he felt like something in the air triggered his asthma symptoms, like he was experiencing wheezing, he was feeling shortness of breath, chest tightness. So he tried to use his inhaler and turned out that he ran out of medications. So he comes again to the clinic to address his symptoms with a rescue breathing treatment. So he's a well-known patient again. He has a history of smoking for 12 years, which he quit 4 years ago successfully. He denies any other symptoms. He denies cough symptoms, congestion, phlegma, chills, fevers, palpitations, chest pain. He denies environmental exposures. He denies respiratory infections recent. He lives with the family. He's independent. He's a driver. He denies using any vaping, any alcohol use, any illicit drugs. So this patient also has a medical history of asthma, which resulted from toxic environmental exposure during his military services. He has PTSD, anxiety, history of traumatic brain injury from the bomb explosions. So he's a refugee of 4 years. He has a maintenance medication of albuterol, fluticasone, sertraline, and hydroxyzine as needed for anxiety. So he's up to date with his flu, with his COVID vaccine and childhood vaccinations, all there. He doesn't have any allergies to medications. He's not aware what exactly triggers the asthma symptoms. So upon arrival, the patient was alert and oriented. He appeared a little bit anxious, a little bit dyspneic. So the vitals were pretty much stable, a little bit elevated blood pressure 140s, heart rate 96, breathing 20-22, again attributed to anxiety and breathing difficulties. He was 92% of room air. We placed him on a mask to make it comfortable at 15 liters supplemental oxygen. So the patient, on assessment, he actually subjectively denied any other symptoms besides wheezing and chest tightness. So all rows are negative. So while we're assessing, physical assessment, it was negative except related to the chest. There was, by the way, no accessory muscle use. There was no bluish discolorations, like indicative of hypoxia, but he was slightly dyspneic. He had diffuse expiratory wheezes on all lung fields. He has a little bit prolonged expiratory phase. We checked the airway obstruction, and it showed like peak expiratory flow was 67% of his predicted peak flow, and it was like 350 liters per minute without supplemental oxygen. So the patient was treated immediately with nebulized albuterol, 2.5 milligrams over 15 minutes. He expressed the relief of the symptoms. We removed the oxygen. We measured him again the patient's peak flow. It appeared to be 440 liters per minute, and it was approximately 85% of his prediction flow. So the patient's primary diagnosis was mild intermittent asthma with acute exacerbations. Concurrent diagnosis included also shortness of breath, post-traumatic stress disorder, anxiety disorders, history of nicotine nicotine dependence, history of exposure to respiratory irritants in the workplace, and history of traumatic brain injury. So once acute asthma symptoms exacerbation were addressed and the patient feel relieved, we discussed the treatment plans. We prescribed him his albuterol, the rescue breathing, again, to use 90 micrograms as a rescuer every 4-6 hours for the shortness of breath. He also reminded that it's important to be to have maintenance medications, because asthma is a chronic condition, chronic inflammatory disease, and he needs to have his combined medication of fluticasone and salmeterol twice a day. So he needs to keep taking it. And here, for this situation, to prevent exacerbation, prevent symptom relapse, the patient was also prescribed prednisone 40 milligrams for 5 days. He was strongly advised to avoid any triggers, any pollution, any smokers around. Notice what exactly triggers that, and also address his psychological stress, because it's a well-known trigger for the asthma symptoms. And anxiety as well. We also was thinking about, while he's stable, maybe reassess him in 1 week. If he's stable, he might get a referral to a psychiatrist for the behavioral therapist to address his anxiety and PTSD. So the patient was advised, if he feels like that his symptoms are not relieved, that he still feels short of breath and he cannot speak in full sentences, his oxygen pulse oximetry drops to less than 92%, he might need to seek emergency department treatment. And yeah, so thank you so much for listening to me. I know it's a little longer than expected, but I tried to combine everything in this interesting case. Thanks.